Hi, so welcome to LTCCC's webinar. We are excited to have Dr. Shekinah fashaw-walters discuss inequities in long-term care. We are the Long-Term Care Community Coalition, a nonprofit dedicated to improving care and quality of life for the elderly and adult disabled in long-term care. We do policy research and analysis, systems advocacy, public education, and we are home to 2 local long-term care ombudsman programs. Today, we have Dr. Shekinah fashaw-walters, whose program is titled A Matter of Justice, Racism as a Fundamental Cause of Long-Term Care Inequities. As a reminder, this program will be posted on our website. You'll get an email with the link that'll have video and it will have slides from the presentation. So about our speaker, Shekinah is an assistant professor in the Division of Health Policy and Management at the University of Minnesota's School of Public Health. And her research focuses on understanding the inequities in aging while elucidating and explicitly naming racism as a fundamental determinant of health inequities within post-acute and long-term care. And unmentioned in this bio is that Shekinah is just an incredible public speaker. I was mentioning to her and Richard and Haley on our call right before this that I just watched one of her keynote presentations where she spoke about how she got into this research field. She spoke about her grandmother, about the importance of valuing our older adults and elderly and aging in home-like environments. And very much looking forward to Shekinah's program today. And I am going to hand it off to you, Shekinah.
Great, thanks so much. I'm going to take a minute to share my screen and get my PowerPoint up for everyone. It is definitely great to be here with you all. I am very appreciative of the invite and looking forward to the time that we'll spend here together. I typically like these conversations to or presentations to be more conversational. So I look forward to the question and answer period following this presentation. I'll also mention, just because I am really pumped up right now, I am leaving a conference and workshop that's hosted here at the University of Minnesota by our Center for Anti-Racism Research for Health Equity, where we've just had a wealth of conversation around what structural racism is and how we measure it. And I like to bring sort of a ton of that knowledge to the work that I do here within the long-term care space. So looking forward to today's conversation. And since I am here at Minnesota, I usually like to open these presentations with a land acknowledgement and just let you all know where we are as a land grant institution. The University of Minnesota, we like to recognize that we gather on the traditional land of the Dakota people, past and present, and we acknowledge with gratitude the land itself and the people we take to heart and commit through action to learn and honor the traditional cultural Dakota values of courage, wisdom, respect, and generosity. So throughout today's presentation or conversation, as I like to call it, we'll be talking a bit about inequities in care and outcomes within long-term care to hopefully assure that we're all in the same place of understanding what's the state of the current literature as we know it. And I'm sure many of you also have your own experiences working within this setting. And then we'll talk about how racism ties into the inequities that we're seeing, what's been shown in the literature, and then we'll also end with a pathway forward. Sometimes these conversations can be really heavy, and so hopefully towards the end we'll have some points where we can discuss a little bit more about spaces where we can advocate around and help to move things forward. So I usually start these conversations giving just an overview of the literature, the seminal knowledge that we have, and where I draw a lot of sort of information from that becomes the basis for how we think about inequities in long-term care. So Black nursing home residents are more likely to reside in lower quality and segregated nursing homes, as many of us know. There is a paper from 2007 that was put out in Health Affairs that describes the racial segregation in the US nursing homes and its relationship to racial disparities in the quality of care. The segregation of nursing homes in this 2000 data used by this study mirrored residential segregation within urban areas. And as a result of this, Black nursing home residents were more likely than white residents to be located in nursing homes that have serious deficiencies, lower staffing ratios, and greater financial vulnerability. This segregation still exists today and poses a serious barrier towards progress. In 2015, almost a decade later, another paper was written on racial segregation and the quality of care disparities in US nursing homes. In this paper, through some fancy econometric analyses, they examine the contributions of travel distance as a source of nursing home segregation, racial disparities, and nursing home quality. And what they found was that there was no evidence of differential willingness to pay for quality by race among first-time nursing home residents, but they did find significant distance effects. So a lot of times where you live really defines the type of services that you can receive. So we'll talk more about that. Another seminal paper written by one of my mentors is entitled Driven to Tears. This was published back in 2004. What it found was that lower tier nursing homes consisted of facilities housing mainly Medicaid residents, and these facilities had very limited resources. So nursing homes serving more Medicaid residents had fewer nurses, lower occupancy rates, they had more health-related deficiencies, they were more likely to be terminated from the Medicaid or Medicare program, and they also were disproportionately located in the poorest counties and more likely to serve Black residents than any of the other facilities. So we talk about this two-tiered system of nursing homes. In 2008, another paper came out about the relationship between state Medicaid policies and nursing home racial composition and the risk of hospitalization for Black and white residents. And it found that increasing Medicaid reimbursements by $10 could reduce the odds of hospitalizations by 4% for white residents and 22% for Black residents. Another older paper in 2009 on Black-white disparities in nursing homes found disparities both within and between nursing homes. So not only were minoritized residents accessing lower quality nursing homes but even within the same nursing homes as their white counterparts, they may be experiencing differences in the quality of care. So this examination of within and between nursing home differences and disparities is so important because of what it means for interventions that are either based on interpersonal, and we'll talk more about what that means, interpersonal discrimination, or structural racism or discrimination. And so we can discuss that a bit more and how racism ties into this. I do want to pause and say, although there is this wealth of literature on racial ethnic disparities in nursing homes, none of these older studies took the time to identify and explicitly name racism as the cause of these disparities. But hopefully by the end of this presentation, you'll see that racism really is the common thread throughout all of these disparities that we see. Another paper that I often turn to by one of my mentors, one of the reasons that I'm here, Dr. Latarsha Chisholm, talks about financial and quality performance and how this differs between nursing homes with high proportions of Black residents and nursing homes with no or medium proportions of Black residents. It found that nursing homes with no Black residents had higher revenues, higher operating margins, and even though their total profit margins were higher, they exhibited better processes and outcomes than nursing homes with high proportions of Black residents. And so she concluded that nursing homes' financial viability and quality of care are influenced by the racial composition of nursing home residents, and in turn, by racism itself. And so policymakers need to consider initiatives to improve both the financial and quality performance of nursing homes, but especially of those serving predominantly Black residents. And then the last piece I like to point out here is that these disparities don't differ for residents with dementia. In fact, there's oftentimes an interactive effect that we see where racial ethnic disparities are exacerbated by the presence of dementia as well. In terms of quality measures, Black nursing home residents have a higher risk of antipsychotics, physical restraint, catheter use, and feeding tube use. Black residents are less likely to receive vaccines or have their pain treated appropriately. They have higher rates of hospital deaths and lower rates of hospice use, all of which are very important measures of quality. These are the sorts of quality measures, as you all know, that CMS looks at in order to provide these 5-star quality ratings. But as we can discuss further, these quality ratings really don't consider the disparities that exist, and in turn, don't do much to mitigate these inequities and may actually exacerbate the disparities we see. And then lastly, in terms of inequities that we see, older adults of color have a lower quality of life. And we also know that fewer older adults of color use assisted living. There are differences in home and community-based services access and quality. And there has also been an increase in nursing home use by minoritized residents, which a recent project of mine has also explored. I do want to pause and sort of mention some of the language that I'm using here. A lot of times in this older literature, we'll see folks referred to as minorities, but we actually know that the demographics are shifting where the minorities are actually starting to become a majority. And so I oftentimes will use terms such as minoritized populations, because this is more about the act of minoritizing or marginalizing a group of individuals and less about who that group of individuals really is. When we talk about disparities, I think it's important to really think about the difference between a disparity and inequity, or even a difference. There can be a difference that exists, but that difference may not actually be a disparity. And what we are talking about when we're talking about disparities are differences that actually exacerbate or further disadvantage already marginalized and disadvantaged communities. And then once we start thinking about inequities or equity itself, we're talking about a matter of justice. We're talking about something that is unfair. We're talking about something oftentimes that is avoidable. And so that is sort of the difference. And I lean more towards talking about inequities because we know that many of these disparities are driven by structural racism, which is something that is unfair, unjust, and something that's avoidable. I also really like to show this graphic. I've oftentimes only seen it with equality and equity pictured, but here there's this graphic that shows both reality and justice. So our reality is disparities exist. You know, a lot of times in this disparities and health equity research, we talk about how we've already documented. I show you 3 slides of these inequities, these disparities already documented. We know they exist, but now it's about getting deeper and understanding why they exist. So the reality is disparities exist. If we think about disparities in the lens of everything should be equal, this really assumes that everyone benefits from the same supports, but really equality can exacerbate disparities. And so I'll show you a little bit more of what that looks like as it relates to nursing home policy. The other piece of this is equity. Equity says that everyone needs to get the supports that they need. Okay, so you can see the shorter person in this graphic has 2 boxes, as opposed to the taller person already has what they need. And so there's no need to add any boxes under that person. So then the last piece of this, which is a newer piece that I really like, is justice. Justice says that the causes of inequity should just completely be removed. These systemic barriers should be addressed and removed. And so that is what our work in long-term care really needs to start moving towards, is more of justice, less of equality, more of equity. Researchers oftentimes say that zip code is a better predictor of health than the healthcare received. But I like to say that's because your zip code predicts the healthcare that you can receive. We know from different parts of the literature that high quality providers, whether they be physicians, hospitals, assisted livings, today we're talking about nursing homes. Some of my work is also on home health. We know that these higher quality providers, regardless of the services they're providing, that they're less likely to serve within disadvantaged or minoritized communities. And more broadly, when we talk about zip code, what we're really talking about are the social determinants of health. Many researchers have identified and are still working to identify and build the connections between the social determinants of health and health outcomes. So many of these social determinants of health can be linked to health inequities as well as structural racism. And where there are some folks who may say that the racial disparities we see, the ones I showed you in the first few slides, are pretty simple. They're all driven by economics. If we paid more or if people had more money, that's sort of that would be the deciding factor. That's what would create the change. But and in turn, it's not really about race, racialization, or anything related to racism. However, the differences that we see are actually a manifestation of structural racism. There's been work done to show that structural racism is a root cause for the socioeconomic differences that we oftentimes blame for the disparities that we see within healthcare and even within nursing homes. Racism happens at 3 levels, and I get this from Dr. Kamara Jones, and I like to encourage people to go and read The Gardener's Tale. It really gives a clear picture using a gardener and flowers and soil and pots to allow us to understand exactly how racism is working and how it is operationalized at multiple levels. So when we talk about racism, oftentimes, what people think of is the first level of racism, which is personally mediated or interpersonal racism. And that can be prejudice or discrimination. It can be anything from being followed around in a store to being called a name or being told that you speak very well for a Black girl. And I've heard that myself, and I sort of go, well, what does that mean? Because as a human that is educated, I should be able to speak very well. What does race have to do with that? And so oftentimes when we think about racism, we're thinking about these interpersonal levels. Even when we think about racism and how it might operate within nursing homes, as I discussed that within and between nursing homes, if we see differences within a nursing home, we should be thinking a little bit more about sort of those interpersonal biases that exist. Another level of racism that not much work has been done on this level is internalized racism. And this is what happens when people experience the other two levels of racism, of both that interpersonal, and we'll talk a bit about institutionalized racism. And they start to believe that the racism they're experiencing is justified. It happens when Black and Brown folks start to accept the limitations to their own full humanity. And then it starts to limit how they can dream. It limits their self-expression, it limits their self-determination. And pieces that I think are really important in this long-term care space is that it limits their autonomy and their dignity, their right to know what is fair and what is just in the places that they're aging. And then the last piece, or the last level of racism, is this institutionalized level of racism. And I will pause and say that although there hasn't been much work done around internalized racism, I don't think we can address internalized racism until we address institutionalized and interpersonal racism. So institutionalized racism is normative. It's oftentimes legalized, and it's important to remember that it's inherited advantage as well as inherited disadvantage. Oftentimes in these conversations, I hear people say, but I'm not racist. And sure, maybe you as an individual, you aren't racist, but in many ways, you may have inherited advantages from a racist system. And as a result, then you also have the power to change that system. So I like us to keep this in mind within these conversations and during these conversations of structural and institutional racism. You yourself may not be racist, but you may in many ways be complicit with the powers that be. And I like to admit, as am I in many ways, as an Ivy League educated, now R1 research assistant professor. And it's important that we start to check these privileges at the door before proceeding into these conversations to understand the lived experiences of many marginalized populations. Racism can be found in past, present, and future policies that hurt disadvantaged communities. It leads to an uneven distribution of almost everything and anything you can think of, including material resources. So that's money, housing, healthcare, access to nursing homes, quality of nursing homes. And it also leads to an uneven distribution of power. That is to say, who's in the popular media, who can run for political office, and whose voice can be heard. It explains the connection between socioeconomic status and race within our country, as I mentioned earlier, and it is the most fundamental of the three levels of racism that we discuss here. And honestly, this level of racism must be addressed for important change to truly occur. These structures of racism were often created deliberately via processes, most notably of redlining and predatory lending. And I like to guarantee people, and I feel like I can say this pretty boldly, that we will continue to see structural and institutional racism found in our future policies if we remain colorblind in our policies and our practices. And when I talk about policies, I'm talking about big P policies at the federal level, as well as policies and practices within nursing home organizations. Racism is a large interconnected system of structures and policies that both, again, advantage and disadvantage people based on the social construction of race. There's nothing about race that is biological. That is to say that race has been socially constructed and created through structures of white supremacy to place one group above another group. There's nothing genetic about race, okay? There is actually more genetic diversity in each racial group than there is across racial groups. So structural racism, as I mentioned, is a system. And the word that strikes me within this definition that's on your screen is the word norms, because norms are an everyday thing that we don't bother to question, right? It's that comfort zone that won't allow us to progress. And I like to say it's no wonder why when COVID-19 happened, happen and it started to change our everyday norms, and we've all gotten used to this new normal, that many of us started to see racism and disparities in a whole new light. I don't think that the world would have awakened to the murder of George Floyd in the way that they did if we had not been in the middle of a pandemic, because George Floyd and what happened to him was not a new occurrence for a lot of folks within the Black and Brown community. This was not something that we woke up and went, oh my God, another one. It was sort of like, another one, right? And so I think as norms start to shift and change, that's when we start to have new ways in which we can see racism come to light. I like to share various definitions, so I have a couple more for you, but I like this definition of structural racism by Bailey that says structural racism is the totality of ways in which societies foster racial discrimination through mutually enforcing these systems, I like to say, that make up our social determinants of health. Because if we go back a slide, you will see that many of those bolded characteristics that I had there are also aligned with those structural determinants of health. Structural racism is also defined as a macro level system or macro level systems of social forces, institutions, ideologies. So there's a piece of culture there where racism becomes embedded within a culture, and processes that interact with one another to generate and reinforce inequities among racial and ethnic groups. One of my mentors, Dr. Gilbert G., describes racism as an iceberg. And we know from icebergs that what you see on the surface is the least of your worries. Here, what you see on the surface of overt white supremacy, of socially unacceptable racism, are forms of racism that we think we've gotten rid of in a lot of different forms. But under that, underneath the surface are even more sort of difficult problems to deal with, right? So although these sort of covert forms of racism that lie under the surface may seem mundane, they have a weathering effect. So racial segregation, wage gaps, food scarcity, all of these are a form of what some scholars refer to as new racism. There's also an issue of colorblindness, which you'll see really close to the top of the surface, that's right under that line. And this thought that we are in a post-racial America. And honestly, these thoughts of colorblindness and being in a post-racial America are sorely misguided. These are also forms of racism. As are many of the other issues that you see sort of lying below the surface in this pyramid. I like to refer to the election of Obama as a symbolic barrier that's being eroded. But in actuality, what I've learned is that covert racism thrives off of these illusions of a colorblind or post-racial America. And these colorblind policies can be very deceiving. So we see racism manifested through multiple different forms, whether it's race science, police brutality, residential segregation, environmental racism, education, our criminal justice system, so many different levels. And so now you're probably wondering, well, how is structural racism manifested within long-term care or long-term services and supports? And so I like to make a few broad connections, and I'm happy to talk about these more deeply as well. But the first one I like to call out is the availability of long-term care resources and services. What we've seen over the years and what research has shown is a white flight from nursing homes that's very similar to the white flight from neighborhoods where minoritized residents started to move only a few decades ago. Research also shows us that community-based options, such as larger assisted living facilities, are less likely to serve in underserved or minoritized low-income communities. the availability of high quality long-term services and supports in nursing homes is also a really big concern. Nursing home care, as we saw from some of the literature early on, is highly segregated, and high proportion Black and Brown nursing homes, those nursing homes that serve a high proportion of Black, Indigenous, and other people of color, are structurally different from primarily white nursing homes. And as I mentioned earlier, they have fewer staff, greater reliance on Medicaid reimbursement, and this reliance on Medicaid may not actually cover the cost of care. So we see that a lot of those organizational features that are associated with lower quality care and lower quality of life are oftentimes centered within these nursing homes that have higher proportions of Black residents. I also like to point out colorblind policies. Okay, so or first, let me talk about COVID-19 and environmental racism. So environmental racism is the idea that minoritized populations are centered within certain environments that are riskier for their health. So it's not that being Black or living in a predominantly Black neighborhood is a risk for your health. The issue is that these neighborhoods have been redlined to particular areas that are more riskier for your health, whether that be contaminated water, and we think about Flint, Michigan, or whether that be in tough hurricane zones, and we can think about what happens to nursing homes during Katrina or other natural disasters. And then we can also think about COVID-19. So a lot of predominantly Black nursing homes were in neighborhoods with higher transmission rates. That is not by chance, that is not random, that is structural. Another piece now that we can talk about, well, let me add this in here around the low pay and limited benefits for direct care workers. This is another way that we see sort of racism manifested, because we know that these direct care workers are more likely to be immigrant women and to be people of color. There's also this issue of sort of Americanized food choices or even white-centric activity programming within nursing homes. So there's some qualitative research out here from one of my mentors here at the University of Minnesota, Dr. Tatiana Shippey, that talks about and really quotes some really strong things from nursing home residents that talk about there are games that I'm not interested in playing, or there's food that does not reflect my culture. And those are other ways in which we see this white-centric idea or white supremacy being imposed upon minoritized populations, making it more difficult to successfully age within long-term care facilities. And then the last piece, the piece that I've been itching to get to, is around colorblind policy making. So colorblind policies such as the 5-star rating system have been shown to exacerbate disparities within nursing homes. And I also do some work to look at this within other community-based options. So it's not specific only to nursing homes, but what we see is a decreased access or decreased quality of care when we apply these really blanket policies such as public reporting or pay for performance. What we see is that that exacerbates disparities in access, inequities in access, as well as inequities in care. I wanted to point out one of the first studies that I did around inappropriate antipsychotic use in nursing homes. Here we identified that inappropriate antipsychotic use was highest in Medicaid-reliant nursing homes. There was no surprise there. And then we also found that it was higher in low Black nursing homes. And this seemed quite contrary to what we thought we would see or what we expected to see. So there's another study that was published recently and was also featured in the New York Times around schizophrenia reporting in nursing homes. So after that strange finding of antipsychotics being lower or being lower in high Black nursing homes and lower in low Black nursing homes, I started to wonder, okay, we're measuring inappropriate antipsychotics. So is there something that might be happening here where nursing homes might be finding a way to change the way things that are reported? And as I was exploring that question, I started to look more at the National Partnership on Dementia Care. And it definitely has been heralded as a success in reducing antipsychotic use across the board. But now we have to start to think about sort of the unintended consequences of this colorblind policy. This policy that comes out and says, we're going to improve dementia care for all nursing home residents. In actuality, may not have made a difference for Black nursing home residents. And many of you may be familiar with this study or may be familiar with sort of this idea. The New York Times did some work on this to show this, but what it looks like is that schizophrenia reporting after the introduction of this partnership to decrease antipsychotic use actually increased for Black nursing home residents with dementia specifically, while it was decreasing for all other nursing home residents. So again, when we talk about this within and between nursing home inequities, what we're seeing here is actually a within nursing home inequity, which means Black nursing home residents with dementia are being treated differently than other nursing home residents. Now, I have to say that this work here is not statistically causal, right? And so a lot of times we hear questions as equity researchers and those doing work on racism about, well, is this causal? Are you saying that this caused this difference? Statistically speaking, no. But what we know in practice and in reality, what we know from lived experiences is that racism does cause these differences. It allows policies to come in and exacerbate inequities that already exist. So after all of that information of doom and gloom and really understanding how pervasive racism is and how it even permeates the walls of nursing homes where folks go to live the last years of their life or even to receive post-acute care, I have to start to think about where is the light at the end of the tunnel? Where can we see policies for advancing health equity? Also recognizing that policies sometimes exacerbate disparities. Where can we create change to see advancements in equity? I think the first piece is making sure that policies are targeted, okay? No more blanket policy improves quality for everyone. We have to be really strategic about targeting high Medicaid nursing homes in order to increase their pay or in reimbursement, or targeting nursing homes that are predominantly Black in order to better serve those populations that have been so underserved. And we can see that through the data and over decades has not really changed has not really changed very much. So targeting nursing homes, I think, is one of the biggest steps. And then the next two things I have here are around increasing nursing staff levels and as well as increasing Medicaid reimbursement. I shared sort of the study earlier about how increasing Medicaid reimbursement by $10 could drastically change things for Black nursing home residents, much more than it would for the white nursing home residents. So that lets us know how much structural racism is really linked to the inequities that we see. Higher nursing staff levels are associated with higher nursing home quality. But Black residents are more likely to live in nursing homes, as I mentioned, that rely on Medicaid reimbursement and have lower staffing levels compared to white residents. And so racial and ethnic disparities are inherently linked to this payer mix and reimbursement rates and payment models. And so nursing homes, they can be very responsive to reimbursement levels and increasing staffing levels when Medicaid or Medicare increases their reimbursement rates. And because we already know that from the literature, that's even more reason for us to advocate for increased increases in Medicaid reimbursements. And although some of that has happened with the COVID-19 pandemic, how much of that is sustainable and how can that be sustained, I think is a really big question that needs to be grappled with. Another piece here is adjusting sort of our pay for performance and our public reporting for the social determinants of health, as well as racism itself. So tying this risk adjustment and pay for performance models to the social determinants of health is really important. Right now, as it stands, many of these pay for performance and public reporting and value-based purchasing models do not take into account the historic structures that exist that exacerbate inequities for the long-term care population. We also have to consider measures of health equity. So if nursing homes are competing for higher quality metrics, whether it's decrease inappropriate antipsychotics, we should also have a countermeasure to understand, are there changes in schizophrenia rates, for example, and other measures of health equity are so important to start to develop and to advocate for and to start implementing within how payment structures work. I know there's another webinar coming up later this month about culture change. And what we found in some of our research is that implementing and encouraging culture change is so vitally important. And we don't see it enough within Medicaid reliant and high proportion Black nursing homes. So encouraging this, providing resources for culture change is a really important policy and practice for advancing health equity. And then I think tied to that is improving staff experiences, benefits, and pay. We know that if we have a happier, more well-supported staff, that inequities will decrease, that there are improvements in the quality of care. And so I will pause there. I think I've left a good amount of time for questions and answers, so we can go into some discussion now. And if there's anything I need to go back and clarify, I'm happy to do that. I hope I didn't fly through that too quickly.
Thanks. I'm going to quickly, you teed us off to promote our upcoming webinar on culture change. So I'm going to just quickly get back to my PowerPoint and share some of the information for that program, and then we'll have some time for Q&A. And a reminder, you can put questions in the Q&A and we will do our best to answer them. So sharing from current slide. Great, so you teed us off perfectly. In a couple weeks, we have a bonus March webinar about nursing home culture change, about the history, the models, the research and policy recommendations. Nina Lowenstein, our legal analyst, will be the presenter, and you can register for this program at the link here, bit.ly/nh-culture-webinar, and it'll be put in the chat. We're looking forward to that. And for other materials, again, we will post the video and slides from this program on our website at nursinghome411.org. And again, this is the link to the upcoming March webinar. And lastly, if your program supervisor, and if you're a New York long-term care ombudsman and your program supervisor allows credit for attending this training program, please take the quick survey at surveymonkey.com/r/LTCCC-LTCOP1. We will put that link in the chat. And thanks for an excellent program. We're going to move on to Q&A.
Thanks. That was so interesting, Shekinah, and really thought-provoking as well. So thank you. We do have a couple of questions. I'm actually going to take the host prerogative and ask my own question first. You had mentioned that that there was increased funding that nursing homes, of course, received during the pandemic. and that's not sustainable. Which of course, obviously, for those of you who are not as familiar, through the CARES Act, nursing homes received many billions of dollars of funds to support their providing good care and quality of life and services to residents in facilities that are certified under the Medicare and Medicaid programs. I was just wondering if you knew of any evidence whether that made an improvement in the care or services, particularly for facilities that are serving a people of color or a large number of people that are, as you call it, minority, majority, et cetera.
Yeah, that's a really good question. I am not too familiar with any literature that's come out specifically about that. I know there was just sort of a lot of questions around where that money was going, right? So if we reimburse or we incentivize nursing homes for lower rates of COVID or for their quality of care around COVID, that already disproportionately positions nursing homes with a higher proportion of Black residents, because we know that those nursing homes are in counties and neighborhoods with higher transmission rates. So I know there was a lot of concern around that. I don't know of any sort of empirical evidence around how that money may have impacted, but I will definitely be on the lookout to see. And if it's not out there, I'm sure it should be soon.
Yeah, interesting. Before we move on, as you were talking, I was thinking also, the states got incentives for doing infection control inspections, and it would be interesting to see where they went, because I assume there'll be a record, of course, of where they conducted those surveys, and that would be interesting too to see how that was targeted. And if that was effective in addressing some of the issues that you've raised. So this actually relates to two of the questions that we've received. One is from an anonymous attendee. How do we know which nursing homes have more minoritized residents?
So we know that from data. I think there's some publicly available data that can be used, like the long-term care focus that's housed at Brown University. And we could also know that somewhat from location, right? So if we look at census data and we find those neighborhoods that are predominantly Black, those nursing homes will be more likely to have more minoritized residents. But definitely some publicly available data out there. And you can look for nursing homes. I think the average is about what we consider a high Black or high minority nursing home would be a nursing home with less than 70% of their residents identifying as white. So it really still is, and I think it varies by state. So you have to think about that as well, because it depends on the racial makeup of the state. But that's sort of the general national number that we go with.
Interesting. I actually have a follow-up question to that. We've been thinking about this a lot and how to kind of to get at that. And the information, I think, on like public information on by zip code or by county on racial profiling is very accessible. Less accessible, although we actually just downloaded the LTC Focus database a couple of days ago, and I know that it has some of those underlying data as well. But I guess my question is, do you see discrepancies between the location of the nursing home and the nursing home population, or do you, in your view or in your perception, do you think that they kind of match?
I think they kind of match. At least that's what the literature has said. So one of the studies I showed in that first slide, happy to share a citation later, but it talks about how the segregation of the nursing home, so that racial composition of the nursing home align pretty well. I don't want to say exactly, but pretty well with the racial composition of the neighborhood itself. So I imagine that still continues to be the case because of where folks want to be, right? In relation to their other family members,
Sure.
caregivers, friends, that sort of thing.
And I would say also where they're sent, where, even they wanted to go someplace else, they may not have, like, say, thinking about a city like New York or any other major city that has wealthy areas, poor areas, et cetera. Is that I bet that you're directed to specific places based upon where you come from and what you look like. Interesting. These are all interesting questions. So thank you. The next question is from Pam Waltz, and it is, can you talk a little more about adjusting for the State Department of Health / racism in reimbursement? What should we look for in advocating with our states around their value-based purchasing or pay-for-performance policies?
Yeah, that's a really good question. So right now, one of the reasons, I guess, I should start with the reason we talk about adjusting for the social determinants of health or racism is because we know that those are some of the main causes for the inequities in care that we're seeing, as well as the quality of life. And if we are paying nursing homes or reimbursing nursing homes that are already doing well at a higher rate, or we're penalizing nursing homes that aren't doing well, then we are just contributing to the problems, right? And so, and I do want to address a comment as well that I saw in the chat that, however, these Black nursing homes are providing poorer care is what the comment says, and that Black families tend not to push back as much as white families. And I think this is, how racism has been ingrained within our system and within our ideologies and culture, to not know that perhaps there is a higher level of care that I could be asking for or that I could be receiving. And so I think there is a sort of a knowledge disconnect there, as well as this idea of privilege. When we're talking about racism and white supremacy, even, it is really a function of privilege. Do you believe that you have the privilege to ask for better care or receive better care? And so because some of those issues exist, and when we talk about social determinants of health, whether it's housing or location, when we don't adjust for those within our reimbursement models, we're sort of just sitting policies on top of those things, right? So we're not mitigating those things, and we're further disadvantaging those nursing homes that could actually use the reimbursement. So they're already low resource nursing homes. That's why the quality of care is poorer. It's not because Black people are choosing to go to lower quality nursing homes. It's because they have fewer resources. And so when we penalize them for serving the populations that might have worse outcomes, once again, connecting back to structural racism, then we are not supporting them in improving the quality of care. I hope that that makes sense. It's kind of a cyclical answer, because that's really what this is. It's a system that's interconnected. It's a cycle that seems to never stop, but there's a lot of work that we can do in terms of policy. I want to direct you to a paper that we recently wrote and published on evidence for action. And I think this paper is in JAMDA, and it's called Addressing Systemic Racism Across Long-Term Services and Supports. And it provides citations for some of the literature within social determinants of health, as well as some of these other policy recommendations that hopefully you can dig a little deeper into to provide more clarity on what can be adjusted for and how it can be adjusted for. I will say this is still in the works, right? We still don't have a clear measure of racism. And so it's going to be hard to adjust for that. But that's something that we're working towards.
So the next question is from an anonymous attendee. And this person asked, are there quality of care disparities between for-profit versus not-for-profit nursing homes that impact minoritized residents?
Yeah, there are. And there's, I think, a wealth of literature on that as well, that there are quality differences between those two, and it tends to be worse quality of care within for-profit nursing homes.
Thanks. Yeah. And that's of course what we, unfortunately, what we see, not every nursing home, but I think that overall industry-wide.
Yeah, as we say, the aggregate.
The next question is from Sarah Shana, and she refers to Joan Burke's question about addressing the care workers, which was, I think, more of a comment, but I'll read Joan's, which was, I thought it was an interesting comment. So Joan had commented, most of the direct care workers are people of color who are less likely to question or challenge the system of which they're working because of the need to maintain their jobs. Another way, racism by the administration and care provided continues to be substandard. And I thought that was an interesting comment. And then Sarah Shana here says, regarding a question addressing the care workers and their reluctance to challenge the system in which they work, as minoritized people themselves wanting to avoid risks of their job. So that's not a question, I'm sorry. It's more another comment, and an interesting comment, but and then Douglas Samuels asked, can we talk about how Black national organizations like the Urban League or the NAACP are addressing the concerns you addressed in your presentation today? Thank you.
Yeah, that's a great question. And to be honest, I do not have an answer for that, but it's something that I will admit, I feel like I've been stuck in this academic world for a very long time, but it's something that I will definitely take a note of and think a little bit more about. I know locally, some of our local organizations here in Minnesota are hosting a wealth of informational sessions to educate and get the information out there and empower groups to seek better care, higher quality care, to advocate for themselves within nursing homes. So I wonder if national organizations are doing this on a broader level, but I do not know personally. So that is definitely something worth looking into. And I will do that. Thanks.
I've tried to reach out a couple of times over the years, especially when there's something that has come up similar. It wasn't specifically the Time story that you mentioned about the rates of schizophrenia diagnoses among residents of color, but there were other studies, of course, throughout the years that have, shown exactly what you were talking about today. And I haven't been able, really gotten any response, unfortunately. But I think it's obviously it's important and valuable. We have a question from Barry Bertel. Does the staff being mostly Black and brown personnel make any difference in the treatment dealing with racism?
Yeah, there's a lot of work around racial concordance between patients and providers, but I think the issue with nursing home staff and other direct care workers is that there isn't much mobility for people of color. So although we see the staff makeup of sort of these direct care workers, the nursing staff being more women of color, oftentimes that does not translate to management. That doesn't translate to those who are making decisions, those who are deciding where the money is going. And so it is hard to see those, I don't want to call them smaller actors, but it's hard to see direct care workers or nursing staff being able to really make a large scale structural change. On an interpersonal relationship level, I think that helps to improve the quality of life for Black residents within nursing homes, but it is not making a huge difference structurally, which is sort of our goal here. And so there needs to be more upward mobility and space for advancement for these women of color that are working as nurses within the nursing home.
I just have a follow-up. I know we're approaching the end of the hour. I'm just wondering, are you aware of any programs or activities to foster greater representation among people of color in higher rankings of the industry, such as the administration level, such as the in the lobby associations on the state and the national level? It'd be interesting to, it seems to me like it'd be interesting and worthwhile to have that.
Yeah, I haven't seen anything. I don't know of anything specifically, but I like the idea.
Yeah.
And I've heard of it in other sectors. I don't know
Right.
of it specifically in nursing homes. Also something worth digging into.
Yes.
And working a project around, if nothing more. So I'd love to talk about that more for sure.
Yeah, thank you. Well, this has been wonderful, and thank you so much for your presentation. Thank you, everyone, for joining us today. Eric, do you have any wrap up or?
No, just we will be posting video and slides of this program, and we hope that you review it and you share it with your networks because we think this is an important topic, and we hope to see you on March 29th.
Yeah, thank you. Thank you again.
Thank
Bye-bye,
you,
everyone.
everyone.
Bye-bye.